Hello and welcome back to this discussion on endocrine emergencies. I'm Professor Adam Thompson, and this is going to be a little bit more lengthy of a video because this discussion is going to include everything related to the endocrine system as it has to do with blood glucose. So we're going to talk about the pathophysiology, assessment, and management of glucose metabolic derangements. Remember, endocrine disorders are caused by either hypersecretion or insufficient secretion of a gland, specifically hormones, right? And hypersecretion represents an overactivity of the organ regulated by the gland, where insufficient secretion of a gland presents as underactivity of the organ controlled by that gland. Glucose metabolic derangements or disorders are caused by dysfunction of the pancreas. Remember that pancreas is where we get either glucagon or insulin, and impairs the body's ability to metabolize glucose when you have an issue with the pancreas. So the effects of a disturbance of the endocrine gland function are determined by both the degree of dysfunction of the gland and the age and the sex of the patient. The most significant endocrine emergencies result in a compromise of your airway, breathing, or circulation, an improper fluid balance, deteriorating mental status, or abnormal vital signs and blood glucose levels. These patients can be in shock, they could be hyponatremic, hypoglycemic, all of these things, and have serious conditions. So I'm sure you're familiar with the term diabetes, or you've heard of diabetes before. And diabetes is simply a metabolic disorder encompassing of a group of complex diseases with many different causes. You have diabetes mellitus, gestational diabetes, hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. And we're going to talk about several of these in this discussion. So when most people tell you they have diabetes, what they're talking about is diabetes mellitus. And diabetes mellitus is a metabolic disorder in which the body's ability to metabolize simple carbohydrates is impaired. Usually this is due to lack of insulin. Remember, insulin is the key that gets sugar into the cell. So diabetes mellitus is characterized by three classic findings: polyphagia, polydipsia, and polyuria, all classic symptoms of new onset diabetes or unknown, uncontrolled diabetes mellitus. So polyphagia is an increased appetite. And this is caused by the inability of glucose to be transported across the cell membrane. Remember, the blood glucose level will be high. So if you were to do a finger stick with a glucometer, it's going to say that the blood glucose level is high, whatever the number may be. And the sugar is not getting into the cell. That's why there's so much in the serum of the blood, because it's not getting into the cells via insulin. That's why their blood glucose level is high. So since the sugar is not getting into the cells, the body thinks that there is no sugar, and it's telling you to eat more. So you have polyphagia. Polydipsia is significant thirst. So polyphagia, hunger, polydipsia, thirst. And the reason you're so thirsty is because you're dehydrated due to the increase in diuresis. And what is diuresis? Well, that's the polyuria. Polyuria is a passage of a large quantity of urine with blood glucose. All right, or with glucose rather. All right, so because of all the sugar in your blood, your body filters that out because you're not using it, and it filters it through the urine. And as you're filtering it through the urine, you're peeing a lot, you're urinating a lot. That's polyuria. That causes the polydipsia because you'll become dehydrated. So it's important to remember that along with oxygen, glucose is the body's primary fuel for cellular metabolism. So along with oxygen, glucose is the body's primary fuel for cellular metabolism. It goes through that citric acid cycle or Krebs cycle to produce ATP, which is, all the energy, in a body for anything that the body has to do, it needs ATP. So that's where it comes from, is glucose or dextrose. You can use those words interchangeably. Dextrose typically is the word we use when we're talking about giving it exogenously. We give people dextrose, but you could also give them oral glucose. So it's just a different name. Now, diabetes mellitus is when the pancreas does not produce enough insulin, or the body's cells do not respond to the effects of insulin that is produced. So in either case, there is an elevated level of glucose in the blood and glucose in the urine. Remember that polyuria. And the glucose builds up and flows out of the body. Cells can starve for glucose, and that's what creates the polyphagia, the hunger. According to the 2014 National Disease Statistics Report, there are 29.1 million people in the U.S., which is approximately 9.3% of the entire population at that time, that had diabetes. 8.1 million remain undiagnosed. And in 2013, diabetes was the 7th leading cause of death in the United States. So diabetes mellitus is very prevalent, and all clinicians, especially emergency clinicians, pre-hospital clinicians, should be very familiar with the disease and be a semi-expert on the disease, because it's certainly going to be something that they see quite often, and have to treat, whether it be hypoglycemia or hyperglycemia. These patients, when they become non-compliant, or when they have a change in their medication regimen or increased exercise or so on and so forth, they have changes in their blood glucose levels, and these changes are seen exogenously, whether it be comatose, altered mental status, increased respirations like we see with DKA. All of these things need to be treated. So let's talk about some of these life-altering complications from diabetes. The kidneys. Diabetics, diabetes is the principal cause of kidney failure. The glomeruli of the kidney become sclerotic, which causes necrosis of the papillary tissue, and then nephropathy, which is disease of the nephron. Remember, the nephron is the functional cell within the kidney. And then renal failure will ensue because of high levels of blood glucose. This can result in kidney failure over time. And kidney failure is not good. Obviously, these patients are going to end up needing dialysis, to filter out their blood. Heart disease and stroke. Adults with diabetes are actually 2 times more likely to either die of heart disease or to have a stroke. When I say heart disease, I'm talking about heart attack, right? When diabetes is not properly controlled, lipolysis raises the level of fat in the blood. We call that dyslipidemia, which can actually increase the risk of atherosclerosis and coronary artery disease. On top of that, you have microscopic deterioration of the vessel walls. And remember, vessels are everywhere: brain, heart. We call that microangiopathy, when those little vessels are starting to deteriorate. It's a condition in which swelling of the membrane cells restricts the flow of blood to the organs and tissues. And whenever you restrict blood flow, you can cause ischemia and necrosis, which is tissue death, right? And tissue death of the brain or the heart would be no good. And the central nervous system damage can cause cardiac dysrhythmias. So microangiopathy and neuropathy contribute to an increased risk of what they call a silent myocardial infarction. And that's when the patient has an MI but no chest pain, right? So there may be an atypical acute myocardial infarction or heart attack presentation. The vessels damaged by microangiopathy characterize cerebrovascular disease and are associated with an increased incidence of stroke. Like we said, 2 times more likely. Peripheral artery disease impairs circulation to the lower extremities. Hypertension is present in 2 out of 3 persons with diabetes. So with that impaired circulation to the lower extremities, obviously when they get a cut or any damage to the lower extremity, they're at higher risk of infection. And when your extremity gets infected, if that infection reaches the bone, they may need or require an amputation, and that's very common amongst diabetics. Eye damage is also very common. In adults with diabetes, is the primary cause of new cases of blindness. So diabetic blindness. High blood glucose levels damage the vessels of the eye, and then scar tissue may pull the retina from the eye. It's called retinal detachment. And then cataracts form when fructose and sorbitol are deposited in the lens of the eye. All right, so on top of cataracts and scar tissue, they can actually end up having full-on blindness. So I mentioned neuropathy before. Neuropathy is simply nerve damage that results in the loss of sensation and function. So a lot of these patients will be on gabapentin, which is Neurontin. It's for neuropathy. It often affects the peripheral nerves, which causes diminished sensation and function in the extremities, like paresthesia, which can blunt pain perception, causing ulcers to go unnoticed until they become seriously infected. And again, you put that on top of the decreased circulation, and this is where the person can have an extremity that becomes gangrenous. The gangrene can develop in adjacent tissues due to poor circulation. Infection may spread to the bone, and this, of course, like I said before, can result in amputation. Many conditions associated with diabetes can be delayed or prevented with lifestyle changes and continued management. It's important. Blood glucose levels are more difficult to control during stress physical activity. Chronic and acute complications are associated with diabetes mellitus, more severe in people who require insulin. Obviously, type 2 diabetes is less severe. If left untreated, diabetes leads to organ system dysfunction, wasting of body tissues, death. Is ultimately it's going to result in. And then the severity of complications really correlates with the average blood glucose level and the age that they acquired the diabetes. There's no known cure for diabetes, only treatment. So type 1 diabetes, remember, diabetes, it breaks down into subtypes, and type 1 is referred to as insulin-dependent diabetes mellitus, or IDDM, or juvenile diabetes, because it generally affects children. That's usually where the onset comes. However, we're seeing more and more type 1 diabetics later on in life. Although a hereditary predisposition exists, environmental factors may be part of the cause. The body develops autoantibodies that incorrectly identify the body's own tissue or substances as foreign invaders to be destroyed. The pancreatic beta cells become incapable of secreting insulin and regulating intracellular glucose. And insulin must be administered by injection or with a pump because they're not making it endogenously anymore. And then latent autoimmune diabetes in adults is a variant of type 1 diabetes that occurs in adults older than 30 years old. And like I said, we're seeing a higher prevalence of that, where strict dietary control must be observed. And increased activity and alcohol consumption can lead to low blood glucose levels as well. So obviously, decreasing alcohol consumption would be a good idea. We'll talk about the assessment of the type 1 diabetic. You want to determine whether the patient is compliant with their disease management, if they're taking their medications when they should. With altered mental status, suspect a low blood glucose level, because that's more common. It's very common that these type 1 diabetics take either too much insulin or they take their insulin when their blood sugar was already too low. Additional chronic conditions may include your renal failure. We talked about diabetics being very prevalent amongst the renal failure group, congestive heart failure because heart disease, right? Coronary artery disease, hypertension, vision, and hearing impairment. Assess for signs of sores or infections because these patients can become septic due to those wounds that they don't feel and they're not getting good circulation to. You're going to want to ask about tingling, numbness, or swelling in the extremities, vision changes, headaches, dizziness, blindness, sores in the mouth, recent changes in their bowel movements or their eating habits. Type 1 diabetics are always going to require insulin to be administered by injection or by an insulin pump. It cannot be ingested orally because insulin will become deactivated throughout the digestive process. Some patients use insulin pumps to treat their disease, and this consists of an infusion set, a reservoir for the insulin, and then the actual pump itself, like you see in this picture. The alternative to multiple daily injections is this insulin pump because they just place the catheter once and then attach their pump, in the beginning of the day, and they're good to go. The pump is approximately the size of a deck of cards and weighs about 3 ounces. There's a couple different kinds, but that's generally the size. It can be administered through a catheter under the skin, and it's often set to deliver a basal amount of insulin continuously throughout the day. Alternatively, the pump can be set to deliver a bolus of insulin at specific times, such as meal times when blood glucose levels are a little bit higher. And there's several different types of insulin available in the United States. You have your rapid acting, your regular or short acting insulin, intermediate acting, and then you have your long acting. and it differs in onset of action, duration, and your peak time. A condition becoming more and more prevalent is type 2 diabetes. It's the most common form of diabetes, and blood glucose levels are elevated because the body can't produce or use enough insulin. The pancreas actually produces enough insulin in your insulin resistance diabetes, but it can't use it. That's the problem. In some cases, an abnormal increase in the production of the glucose by the liver causes an increase in blood glucose levels. When glucagon levels remain high, excess amounts of glucose are produced, leading to high blood glucose levels. Metformin, the medication most commonly prescribed for the management of type 2 diabetes, causes a decrease in glucose production. Metformin, or glucophage is the other name for it. Approximately 8.5% of the world's population is affected by diabetes, and usually it's type 2. Approximately 90% of people with diabetes in the U.S. have type 2 diabetes. So 90% of all diabetics in the U.S. have the type 2 diabetes. Development is associated with obesity and physical inactivity. So typically it's poor dieting and lack of exercise that causes somebody to have type 2 diabetes. And development of metabolic syndrome is associated with excess weight, lack of physical activity, and genetic factors. There are many signs and symptoms associated with type 2 diabetes. Some of the symptoms include fatigue, nausea, frequent urination, thirst, unexplained weight loss, blurred vision, frequent infections and slow healing of wounds. They might just be overall cranky, confused, or shaky, unresponsive, or they might even have a seizure. Same as type 1 diabetes. All of these symptoms are, synonymous, both type 1, type 2. Symptoms tend to develop gradually and become noticeable in the middle age. A small percentage of persons do not display any symptoms at all. Management of type 2 diabetes includes weight loss, exercise, and diet. The food intake must be spread throughout the day in coordination with daily medications, maybe even insulin injections. Oral medications may be used alone or in combination. Here's a list of some of the oral agents that are used to treat type 2 diabetes. You can go ahead and pause and look through this list. I'm not going to read it all to you, and then we'll move on. So before somebody becomes a type 2 diabetic, they might actually be a pre-diabetic. And pre-diabetes is related to certain risk factors associated with type 2 diabetes. It exists when blood glucose levels or hemoglobin A1C levels are above that normal level, yet not high enough to be diagnosed as actual diabetes. A1C blood test reveals information regarding the patient's blood glucose levels over the previous 3 months, and it affects about 1 out of every 3 U.S. adults is a pre-diabetic, approximately 86 million people, and 90% are unaware of their status. Within 5 years, and with no intervention, 15 to 30% of those people with pre-diabetes will actually develop type 2 diabetes. Your risk factors of pre-diabetes include age. Of course, if you're older than 45, overweight, there's a family history of diabetes, African Americans, Hispanics, American Indians, Pacific Islanders, and some Asian Americans are at increased risk for prediabetes, as well as the people with gestational diabetes or having given birth to a baby who weighed more than 9 pounds at any point, being physically active fewer than 3 times per week, and then interventions affecting 2 specific factors can help prevent or delay the onset of type 2 diabetes by 58%. Losing 5 to 7% of the patient's body weight would reduce your rate of conversion to diabetes, and then getting at least 150 minutes of physical activity per week. So diet and exercise are the true preventative measures for prediabetes. So I mentioned gestational diabetes. Gestational diabetes is just that. It's diabetes during gestation or during a gravid period where when someone is pregnant, that's when they have diabetes, but when they're not pregnant, they don't have diabetes. So it's called gestational diabetes. It's a form of glucose intolerance that occurs only during pregnancy. It occurs more often in women who are African American, Hispanic, Latino, or Native American, and then those women that are obese or that have a family history of diabetes. They actually do this test where the woman will drink glucola or a sugary water at some point and then get a blood test to see if they have gestational diabetes while they're pregnant. And they have an increased risk of type 2 diabetes, as I just said, and resolves before the delivery for most women, and usually diagnosed at 28 weeks gestation, and it peaks in the third trimester. Hormones produced by the placenta may impede the function of insulin. This could be the cause, and the condition does not produce birth defects, other than typically a larger baby. Women with gestational diabetes typically have larger babies at birth. When it comes to gestational diabetes, the oral glucose tolerance test is used to diagnose gestational diabetes until within 12 weeks of delivery. So that's that glucola I was talking about. The hemoglobin A1C test may be used during the first pregnancy visit to identify the presence of pre-existing diabetes or pre-diabetes, not gestational diabetes, but if they had diabetes before they got pregnant. And then for management, you're just going to stabilize the blood glucose levels as soon as possible. Diet modification, exercise, and blood glucose testing, and insulin injections may actually be required. However, that is less common. Hypoglycemia. Hypoglycemia is typically a more acute condition, where diabetes is the chronic condition. Hypoglycemia could be a result of somebody with diabetes mellitus or diabetes type 2 if they take insulin or too much of their medication. It's just a low blood glucose level, typically 45 milligrams per deciliter or less. However, anything below 60 could be considered hypoglycemic. A common problem experienced by patients with both type 1 and type 2 diabetes. Patients must closely monitor and intensively control their diabetes to prevent long-term complications. Hypoglycemia is relatively common and can be treated easily. Severe hypoglycemia requires intervention and treatment, and more often than not, you treat this pre-hospitally. The patient will go from sometimes they're completely obtunded or severely altered, to being completely compos mentis and alert and oriented, and they may not even remember becoming hypoglycemic. Usually they don't remember becoming hypoglycemic, and they do not want to go to the hospital. It's very common that they do not want to go to the hospital. It is recommended, of course, that they go and be transported, assessed along the way. However, once the patient becomes completely alert and oriented, it is a very difficult case to make to get them to go to the hospital against their will. Hypoglycemia often results from too much insulin, too little food, or both. A combination of both is very common. The central nervous system tissue depends on glucose for energy, and then counter-regulation is the body's natural defensive ability to maintain blood glucose at an appropriate level. So the body's first line of defense is to reduce insulin production by the pancreas and to increase glucagon production by the alpha cells. Remember, glucagon is going to tell the liver to start breaking down glycogen and use that to make sugar, energy. The second line of defense is secretion of catecholamines, including epinephrine and norepinephrine, by the adrenal glands. These effects can be seen as tachycardia and diaphoresis. And it also includes cortisol, an adrenocorticoid. It's a steroid produced in the adrenal glands. Last, stimulation of the autonomic nervous system generates signals that allow production of counter-regulatory hormones to increase. And then the same stimulation also triggers symptoms telling the body that the blood glucose level is low. In patients with type 1 diabetes, the islets and Langerhans do not make insulin. The body's first line of defense against hypoglycemia is lost. Causes of low blood glucose level in a patient with diabetes could be elevated level of exogenous insulin from inaccurate dosing or intentional overdose. It could be a mismatch with carbohydrate intake and exogenous insulin intake, so they may be not eating enough for the amount of insulin that they're taking, or it could be increased use of glucose, such as during exercise, they're burning off more glucose, causing the blood glucose level to drop sharply. In patients with type 2 diabetes, pancreas can generate insulin. However, their bodies may be resistant to the effects of that insulin, and they may not make enough insulin over time to lower the blood sugar adequately. Medications given to treat type 2 diabetes act by either stimulating the body's ability to secrete insulin or by improving insulin's actions. They tend to contribute to hypoglycemia. Some patients who have had type 1 diabetes for many years, and to a lesser degree patients who have had type 2 diabetes for many years, may not have a glucagon release from the pancreas in response to hypoglycemia. the body is more dependent on epinephrine to overcome the effects of hypoglycemia at that point. And yet there may be some lack of responsiveness to epinephrine in diabetes as well. Prolonged disease can also decrease a patient's ability to recognize having a low blood glucose level. It's called a hypoglycemic unawareness, and it prevents the person from actually self-treating before this becomes an issue that they can't treat. When you're assessing these patients, you might notice that they'll tremble, they'll have a rapid pulse rate, that's due to that catecholamine release. They'll sweat, also due to the catecholamines, and they might even feel hungry. If the condition persists, cerebral dysfunction will progress to a permanent brain damage. Common signs and symptoms of hypoglycemia include blood sugar, of course, less than 60 milligrams per deciliter, hunger, agitation, irritability, and combative behavior that cannot be explained. They might have altered mentation or confusion, all the way to coma. Nausea, weakness, tachycardia, cool, clammy skin are all very common. They may be acting like they never would. This could be the nicest person you've ever met normally, but when they become hypoglycemic, they may be terrible to be around. You know, they could be very violent, and it's not their fault. It's of course due to the altered level of glucose in their blood. They also may have headaches, memory loss, incoordination, slurred speech, irritability, dilated pupils, seizures, and of course, in severe cases, they'll be completely unresponsive. Remember that hypoglycemia could develop rapidly, and it should be suspected in anybody that's got bizarre behavior or neurologic signs. Hypoglycemia episodes may also be due to alcoholism, poisoning, or overdose, any kind of toxicosis really, certain cancers, liver disease, kidney disease, some other conditions. Persons with diabetes may also experience head injuries, stroke, seizures, meningitis, or other traumatic injuries or conditions. The management for hypoglycemia is to normalize their blood glucose, right? So you want to immediately increase their blood glucose levels and then use the least invasive method that's necessary. So if they're alert and oriented, totally compos mentis, administer some oral glucose, maybe even food. Have them eat if they can do that. If they're altered or unresponsive, that would be inappropriate, and establishing an IV, giving them some IV dextrose would be a better alternative. If you cannot establish an IV, which is common in diabetics for them to have poor vasculature, you may need to do intramuscular glucagon to get their sugar up high enough to the point where they can get some oral glucose. So whenever somebody's got an altered mental status, you're going to want to rule out hypoglycemia. Do a finger stick, the field glucose test, and find out what their sugar is. And again, if they have a good gag reflex, they can swallow, and they're compos mentis, give them some oral glucose via tablets, gel, or even food. You can mix a little sugar and some orange juice. That's a very common technique that works really well. Of course, if they're not responsive, you're going to avoid that. You're going to do that IV dextrose that we talked about. You're going to want to be very careful. If there's somebody that may be having a stroke or a head bleed, you don't want to give them high concentration of dextrose rapidly IV because if that makes it into the extravascular space of the brain, it could be very necrotic to the tissues around it. That's also an important thing to note here. If you're giving dextrose IV, make sure you have a patent line and make sure regularly, because extravascular dextrose is very corrosive and actually causes necrosis to the tissues of the body. So you want to make sure it's in the blood, and you want to give it slowly through a nice running patent IV line. Aspirate frequently to make sure that you're patent. Make sure your line's constantly running. Dilute as you administer it, and then you're practicing good clinical techniques. Again, if the patient has a decreased level of consciousness, of course, you could always move over to glucagon IM if you're unable to get that IV line. All right, from one extreme to the next, let's talk about hyperglycemia and diabetic ketoacidosis. This is obviously when the blood glucose is high. These levels exceed 120 milligrams per deciliter. Typically, physicians try to maintain levels less than 160 milligrams per deciliter. It can cause by excessive food intake, insufficient insulin dosages, ineffective insulin, infection or illness, injury, surgery, emotional stress. The onset may be rapid, within minutes, or gradual. It could take hours to days. Also, it could be due to just undiagnosed diabetes, your new onset diabetes. that's gone unrecognized. The person could also have sundowners, or the dawn phenomenon, that occurs in the hours before waking. As the body prepares for a new day, it releases hormones such as cortisol and catecholamines, and then these hormones trigger a release of glucose from the liver, and this results in hyperglycemia. The Somogyi effect is a phenomenon that occurs when a low blood glucose level generates a release of hormones that initiate a release of glucose from the liver, causing hyperglycemia. So both cause due to a release of glucose from the liver through that breakdown of glycogen storages. Some patients with type 2 diabetes can go undiagnosed for several years, and repeated episodes of hyperglycemia will cause several physiologic changes that have detrimental long-term effects. Hyperglycemia puts undue strain on the cardiovascular system, kidneys, and other organs that are sensitive to increased serum viscosity and the subsequent pressures exerted by the thicker serum from having too much blood sugar. The eventual result is increased incidence of disorders such as renal failure, as we talked about, CHF, retinopathy, as we've also mentioned, coronary artery disease, and neuropathy. When serum glucose levels rise above tolerable levels, other physiologic changes occur. Diabetic ketoacidosis is when blood glucose levels greater than approximately 350 milligrams per deciliter occur. And then hyperosmolar hyperglycemic syndrome is when blood glucose levels greater than approximately 600 milligrams per deciliter occur. So it's important to know that untreated hyperglycemia will progress to DKA, diabetic ketoacidosis. The associated predominantly with type 1 diabetes. Type 1 diabetes typically result in your DKA. It's a life-threatening condition. Any acidosis is. Your pH cannot withstand too low of a number. It occurs when certain acids accumulate in the body because insulin is not available. So what happens is, since your body can't absorb the sugar that's in the blood, that's why the serum blood glucose is high, because it's not making it into the tissues, your body will start to break down fats, right, through lipolysis. And it breaks down these fats into ketones, and then ketones can provide some energy. You may have heard of the ketogenic diet. That's how, being on a low carbohydrate diet can lead to a ketosis. Now, the problem with diabetics is it can lead to a ketoacidosis because they can't use any sugar. Infection, injury, alcohol use, emotional discord, illness are all common causes. And then patients tend to be teenagers and even young adults. So with these patients, rising blood glucose leads to a massive osmotic diuresis, passing large amounts of urine. The osmotic diuresis and vomiting cause dehydration and even shock. In DKA, the deficiency of insulin prevents cells from taking up the extra glucose. Because the body cannot use glucose, it uses fat, like I said before. The metabolism of fat generates acids and ketones as byproducts or waste products. Because glucose must be excreted in the urine in solution, the body loses excessive amounts of water and electrolytes, sodium and potassium, which may lead to disturbances in water balance and acid-base balances. Large quantities of ketone bodies in the bloodstream causes a decrease in the blood's pH and results in that acidotic state. In patients with type 2 diabetes, DKA is rare because insulin is still present. Remember, the body just doesn't use it very well, at least early on. So how do these patients present? Well, there's many signs and symptoms of hyperglycemia, but it's similar to hypoglycemia. It could have blurred vision, polyuria, polydipsia, polyphagia. Remember that excessive urine output, excessive thirst, excessive eating, orthostatic syncope, frequent infections, skin ulcerations. All of these things are common, but they're also what you might see in somebody that's hypoglycemic. Your hyperglycemic patient, usually this condition has progressed slowly, about 12 to 48 hours, with the patient's level of consciousness deteriorating gradually, unlike hypoglycemia. The load of glucose in the kidneys results in glucose spilling into the urine, causing the body to become hyperosmotic. As the kidneys remove excess glucose, water is removed via increased urination, leading to dehydration. Remember, the polyuria. Kidneys also help clear ketone bodies from the body. So patients lose excessive amounts of sodium, potassium, and phosphate in the urine. This combination of effects leads to both dehydration and metabolic acidosis with associated electrolyte imbalances. And then whenever the body's acidotic, the respiratory drive might increase. So they might start breathing really fast because you're trying to counterbalance or compensate for the metabolic acidosis with respiratory alkalosis, because the faster you breathe, the more CO2 you breathe off, which you can kind of picture getting rid of CO2 causes a more alkaline environment. So Kussmaul respirations, which are deep, rapid respirations, are pathognomic of DKA. Also polyuria, polydipsia, polyphagia, the thirst, the sweating, the hunger, nausea and vomiting, tachycardia, deep, rapid respirations, warm, dry skin, dry mucous membranes, fruity odor of ketones on the breath. However, not everybody can smell the ketones. That's a certain gene that you must have to be able to smell it. So it's supposed to be an acetone smell. However, I've been in the room where with 3 other nurses and only one nurse could actually smell the ketones in a DKA patient. Abdominal pain, hypertension, and sometimes even a fever are present on these patients. So these patients usually appear pretty thin or dehydrated, and they have warm, dry skin. They may also exhibit orthostatic hypotension, supine hypotension, fatigue, altered mental status. With time, weight loss from the hypermetabolic state will occur. Patients in DKA are seldom deeply comatose. So if the patient is totally unresponsive, look for another source of the coma, such as head injury, stroke, or drug overdose. If they are completely unresponsive, this is probably pretty serious DKA. That's probably pretty bad. Respiratory rate is usually elevated and tidal volume is increased, like I said, Kussmaul's respirations to blow off those ketones. They have ketonemia and acidosis. These respiratory changes result in hypocapnia. Again, it's a respiratory alkalosis with a metabolic acidosis. So here's a table that kind of shows some of the comparisons of hypoglycemia and hyperglycemia. Hypoglycemia can be caused by insufficient food intake, where your hyperglycemia can be an excess of fluid intake. Everything's kind of opposite in a way. So excessive insulin dosage with hypo, insufficient with hyper. The onset's rapid with hypoglycemia because, again, the insulin metabolizes all the sugar, where it's more gradual with your hyperglycemia. You have more moist skin. They have they're diaphoretic when they're hypoglycemic, but they're usually warm and dry when the sugar is high. Infection is uncommon in the hypoglycemic patient, and common in the DKA patient, and usually in a hyperglycemic patient. So you could pause this and read all the other comparisons. I'm not going to read the whole table to you. Obviously, the most important thing is the rapid onset with the hypoglycemia, the insufficient food intake, and the insulin dosage. So how do we manage these patients with hyperglycemia or DKA? A physician will probably order treatment for DKA if the patient has history and physical exam that are consistent with DKA, and the glucose level is more than 250 milligrams per deciliter. In most instances, insulin therapy should be delivered at the hospital, not pre-hospitally. Follow the procedure for any comatose patient with regard to airway maintenance and oxygen. Of course, be alert for vomiting and have suction ready and on the go. Start an IV and infuse up to 1 liter of normal saline during the first half hour, or as suggested by your local protocol. If the patient is hypotense, rapidly administer isotonic fluids until systolic blood pressure is at least 80 millimeters of mercury, then slowly infuse after that. Monitor for pulmonary edema because fluid shifting is common. Monitor the cardiac rhythm. Sharply peaked T waves may indicate dangerously high levels of potassium, possibly requiring sodium bicarbonate. Remember the electrolyte changes that happen during a hyperglycemic event. As potassium levels rise, the QRS complex will widen and may blend with the T waves, developing into a sine wave pattern, and it could even become bradycardic. Management with calcium chloride or calcium gluconate may be indicated, even pre-hospitally. So here in this image we have a normal T wave. Here is mild to moderate hyperglycemia becoming a little bit more severe with the peak T waves, and then this is really bad lethal hyperglycemia. When you have widening of the QRS, the P wave will disappear, and you get this straight line from the nadir of the S wave to the peak of the T wave, or from the top of the R wave to the complete depth of the T wave. So that is when the patient has very little time and needs emergent treatment. Get the calcium on board. Hypomagnesemia commonly results from loss of magnesium through the urine. Remember, they got polyuria. This electrolyte balance can worsen vomiting, cause alterations in their mental status, and it will induce other electrolyte abnormalities. It could lead to potentially fatal cardiac dysrhythmias such as torsades, so be prepared to administer the magnesium. Magnesium deficiency from DKA is generally not treated pre-hospitally, though. Complications of DKA are frequently associated with its management, so infusion of insulin may lead to hypoglycemia. Hypokalemia may result when insulin shifts potassium back into the cells, and then cerebral edema may occur if blood glucose levels shift too rapidly, so it's more prevalent in your pediatric patients. Next up, we have hyperosmolar hyperglycemic syndrome, or HHS, and it's also called hyperosmolar non-ketotic coma because it's non-ketotic, it's not ketoacidosis. The metabolic derangement that occurs principally in patients with type 2 diabetes. The term hyperosmolarity describes concentrated blood resulting from relative dehydration. Key signs and symptoms include hyperglycemia, altered mental status, drowsiness, and lethargy, severe dehydration, thirst, and dark urine, visual or sensory deficits, partial paralysis, or muscle weakness, and seizures. So dehydration is the major thing here. So what do you think the treatment is? Fewer than 20% of patients present in a comatose state with this HHS. Most have severe dehydration, focal and global neurologic deficits. Clinical features of HHS, or HONK, and DKA tend to overlap. They're very similar. Often develops in patients with diabetes who have a secondary illness that leads to reduced fluid intake. So they could become, have the flu or become septic, and now they become very dehydrated. When assessing these patients, remember they do not experience a ketoacidosis, so some of the things may be different. For instance, Kussmaul respirations probably won't be present. The onset could take up to weeks. Approximately 30% do not have a prior diagnosis of diabetes, so a third of these patients almost won't even have a diagnosis of diabetes. Stress response tends to increase hormones that favor elevated glucose levels and that often counter the effect of insulin, including cortisol, catecholamines, glucagon, and many others. Neurologic changes may be found, including some drowsiness and lethargy, delirium, coma, focal or generalized seizures if it's severe, visual disturbances, hemiparesis, and sensory deficits as well. So here's a quick table to look at the differences between HHS and DKA. Again, this is a very high blood glucose level, very, very high. The big change here is that one is acidosis, one is not. One is going to be more alkaline, and that's going to be the biggest change. That's because these ketone bodies, they're absent with HHS and they're present with DKA, and the excess of ketones becomes an acid. That's why it's ketoacidosis. And we're going to finish out this lecture talking about the management of HHS. Pre-hospital treatment follows the pathway for dehydration and altered mental status. So airway management is going to be your top priority with anybody that's got an altered mental state. Cervical spinal mobilization should be used if the unresponsive patient is found lying down and there could be trauma involved. A large bore IV access should be gained as soon as possible, but not to delay the transport. Obtain a blood glucose level as soon as possible as well, and bolus the patient at least 500 milliliters of 0.9% normal saline. That would be appropriate. In patients with a history of CHF and or renal insufficiency, consider having the bolus, maybe a 250 cc bolus. And patients may receive 1 to 2 liters within the first hour. So the main treatments for an increased blood sugar is going to be fluids pre-hospitally. You're not typically going to give insulin or anything like that before they get to the hospital. With a decreased blood sugar, with hypoglycemia, the treatment should be least invasive based on their presentation. So if they're alert and oriented, you're going to want to give them oral glucose, maybe even food or some sugar water or a little orange juice. If they're altered or unresponsive, you may want to get an IV and give them dextrose. If you can't get that IV, then you may have to give them intramuscular glucagon. But again, these hyperglycemic patients that we've just talked about, fluids. It's going to be a lot of fluids for these patients.